Dr. Ramanan will be the first person, sir.
First. So we must follow the institute tradition of starting at time.
Yes, sir. No, 30 seconds. ஆரம்பிச்சிடலாம்.
Yes. Good morning. Good morning,
dear friends. I welcome you all to this Clinical Neurology Forum 48th installment. And I have great pleasure in welcoming my good friend and Anna, Dr. Paranjyothi sir, to be the chairperson and conduct the proceedings. All of you know Dr. Paranjyothi. He has been at the helm of Pondicherry Neurology and he will conduct the proceedings. I hand over to him. Professor Paranjyothi sir, please continue. Thank you. I thank CTCS for volunteering to come and conduct this show. He said he will do this and I am thankful to him and his team. Thank you, CTS.
Thank you, Professor V. Natarajan. There is no sir. I think you can cut down my sir also.
Yes,
so,
sir.
Good morning.
Done. Okay, I will not.
Yes. Sorry is not a good term to use for me. Okay. I am not that much old. Okay. Good morning, my dear friends and neurologists, all neurologists. It is my pleasure to preside over this 48th webinar started by Professor V. Natarajan and continuing every month without any problem or any disturbances. In this occasion, this academic forum is very useful to all because here only we are seeing a case managed by
அடுத்த வேலை எனக்கு வந்திருக்கு சும்மா வேணுக்குனே
Sir, please unmute yourself, sir.
Yes.
Sir, there is some disturbance. Yes, sir.
பாக்கி பேர்லாம் மியூட் பண்ணிடுங்க.
Yes, sir. Yes, sir. Sir.
Yes, sir. So, this webinar assumes significance in the sense a case is presented and managed, and then all opinion about the management and investigation is required, and we will be managing it in a different way or the same way or in a better way. Thereby, we are going to modify our neurological practice in future. One such a case will always come, and we have to see that the case is managed in a better way. All the knowledge and wisdom we are acquiring, it is most useful to the patients only, patients one for welfare only. We have the privilege of saving one patient because of this webinar. I will be very happy and see that everyone must follow this advice because we are getting advice from eminent persons, most neurologists on this occasion. Without wasting much of time, I will call upon the first speaker, Dr. Ramanan, DRNB President, Indira Gandhi Government General Hospital and Research Institute, Postgraduate Institute, a case of self-mutilating disorder. Over to Dr. Ramanan. Ramanan, you can take over.
Good morning, sir, and good morning to all the senior teachers and my friends to this forum. And now I'm going to share my PowerPoint. Sir, shall I start with the case, sir?
You can proceed.
Yes, sir. Today, we are going to discuss a case of mutilating disorder. I am Dr. Ramanan, DRNB resident from Department of Neurology, Indira Gandhi Government General Hospital and Postgraduate Institute, Pondicherry. Coming to patient details, our patient is a 15-year-old female. She has studied till 7th standard and she hails from Pudupattinam, Mayiladurai from Tamil Nadu. History was obtained from patient and patient's mother. Chief complaints, she had recurrent wounds over both feet for last 7 years, inability to perceive pain and temperature sensation over both legs below ankle for 7 years, swelling of left leg for 1 month. History of presenting illness. Patient Miss X was apparently normal before 7 years. When she returned from school on one day, she noticed a spontaneous bleb over undersurface of her right great toe, despite not having the habit of barefoot walk. 2 days later, the bleb ruptured after a trivial injury while playing to release a watery discharge, which developed into a wound, for which she did not seek any medical care or over-the-counter medications as it was painless. 2 months later, she developed a similar bleb formation over undersurface of her left foot, which ruptured spontaneously to release watery discharge, which later developed into a wound and it also had no pain. She applied topical ointment from nearby pharmacy and did not seek any medical care. Approximately 6 months later, she noticed loss of nail on her right great toe. After a few days, she also noticed loss of nail on her right second toe, which was not associated with any pain. Subsequently, after a few days, she noticed spontaneous mutilation of her right great toe, which is not associated with any pain. For the above complaints, they attended a local physician and she was referred to a hospital in Chengalpattu. There she was hospitalized for a week and then referred to JIPMER for further evaluation. Patient attended once there as outpatient basis and subsequently did not follow up. She also noticed deformity in her left leg in such a way that first toe and second toe faced towards her right leg. Could not recollect the exact time of onset of the deformity. The wound in both foot was partially healing and recurring without complete recovery till date, but resulting in deformities, which is adding day by day. For last 1 month, patient also complained of swelling of left leg below ankle, which is insidious in onset and gradually progressive in such a way it started from toes and progressed till ankle, which is not associated with any pain, fever, redness, which decreases slightly upon lying down. After approximately 6 months later from the onset of illness, while drinking hot tea, she accidentally spilled the tea over the dorsum of food and noticed that she did not perceive the heat. At that time, she tried pinching herself over her legs bilaterally and noticed that she is not able to perceive the pain sensation below her ankle. The inability to perceive pain and temperature sensation gradually progressed over these 7 years till distal 1/3 of legs. No history of similar sensory disturbances elsewhere in the body. This sensory disturbances is not associated with any difficulty in perceiving hair cloths, burning sensation, pinpricking sensation, insect crawling sensation, tingling sensation, crampy pain, numbness, walking over a cotton wool sensation, unsteadiness while washing face, unsteadiness while walking in dark, history suggestive of radicular pain or electric shock-like sensation upon bending down or band-like sensation. History of dry skin, decreased sweating, and loss of hair over bilateral lower limbs are present, but the patient could not specify the exact duration of the above illness. No history of abnormal bladder and bowel habits, no history of resting palpitations or orthostatic giddiness. She stopped wearing sandals since mutilation of her right great toe, and hence slippage of slippers could not be ascertained from history. However, before mutilation of her toe, she did not had any slippage of slippers or tripping of toes. Also, there is no history of buckling of knees, difficulty in standing from squatting position, difficulty in turning side to side in bed, difficulty in folding objects, difficulty in opening and closing water can lid, mixing food, difficulty in bringing food to mouth, difficulty in picking objects overhead, lifting neck off the bed in sleeping position. There is no history suggestive of floppiness or tightness of limbs. The below are cranial nerve history. In this case, all the cranial nerve related histories are negative. No history of headache, vomiting, seizure, neck pain, photosensitivity. No history of memory disturbances, behavioral disturbances, mood disturbances, delusions, and hallucinations. No history of dry mouth, dry eyes, multiple joint pain, skin rash, oral and nasal ulcers. No history of hypo or hyperpigmented patches over the body. No history of excessive hair fall or cold intolerance, no history of chronic fever, night sweats, chills, no history of abdominal pain, chronic loose stools, and increased flatulence, no history of passing high-colored urine. Past history, she is not a known case of any comorbidities as mentioned, and no history of any toxin exposure or chronic drug intake. Personal history, she takes mixed diet. Apart from that, there is no other significant personal history. Family history, this is a 3-generation pedigree chart. She is born out of consanguineous marriage, grade 3. This is our patient. Patient has 2 elder siblings, both are males and actively and healthily living their life. There is no history of significant illness among family members. Summary, Miss X, a 15-year-old female born out of 3rd-degree consanguineous marriage, presented with neurological complaints evolving over a period of 7 years, which was insidious in onset and gradually progressive in the form of spontaneous blood formation in undersurface of right foot, followed by left foot, which ruptured to release serous discharge and developed into an ulcer, which was followed by loss of nails in right toes, followed by mutilation of right great toe and deformity involving left toes, and swelling of left leg below ankle for last 1 month, which was not associated with any pain, associated with inability to perceive pain and temperature sensations below ankle, without any other sensory disturbances, without any other history of weakness, bowel and bladder disturbances, orthostatic giddiness, palpitations, cranial nerve involvement, higher mental function involvement, and without significant past personal history. So this is the timeline of the patient. 7 years before, that is when the patient was 8 years of age, he had blood formation resulting in ulcer of right leg. After 2 months, blood formation resulting in ulcer left leg. After 6 months from the onset of illness, decreased pain and temperature sensation below ankle. After 8 months from onset, loss of nail over right second toe. And from since then, till 1 month before, she had gradually accumulating neurological complaints in the form of loss of nail over second toe, after few days mutilation of her right great toe, after few days deformity of leg toes. Also, during this period, there were recurrent ulcers over both legs, which were partially healing and recurring. 1 month before, at the age of 15 years, she developed a swelling of leg below ankle. Sir, with this, my history is done, sir. Shall I proceed with the subsequent slides, sir?
No. See, from the history, and you have given a wonderful timeline. So, do you think this blood formation is a neurological problem?
Yes, sir.
If the answer is yes, what are the structures involved in this neurological problem? What are structures involved?
Sir, the entire spectrum which we dealt before,
Because before we
can
go
put in?
physical examination, we must come to a conclusion.
Yes, sir.
Yes, provisional conclusion.
Yes, sir. Sir, all these above mentioned complaints can be put together in a peripheral neuropathy, that too predominantly small fiber involvement, sir.
Yes, good. But the age is very less,
Yes, sir.
without any contributing factor like diabetes or leprosy or other causes. An ordinary individual developing this, what could be the reason?
Sir, considering the long protracted course of the illness and the younger onset of the illness, more likely it is possible to have a genetic background for the above illness, sir. And specifically involving small fibers, it could more likely be hereditary, sensory, and autonomic neuropathy, sir, and its subtypes.
Probably.
Yes, sir.
So, any audience, anybody has got any comments? Before we go into the physical examination, let us have the opinion of others. Anybody?
At present, HSAN looks the most likely diagnosis.
Hello?
Dr. Natarajan speaking, sir.
Yes, sir.
At present, hereditary sensory autonomic neuropathy looks like the most likely diagnosis. unless he comes up with further features, which is in disagreement with that.
Now, can we jump into the hereditary aspect now?
As you pointed out, it's a sensory autonomic neuropathy occurring in a person without any risk factors and in an age group of 15 years, starting around 10 years of age. Very likely that's the age in which these neuropathies start. So,
Okay.
I would say that as the first possibility.
Okay. Anybody else? If there is
Um,
no- yes.
Does the presenter have any, Ramanan, do you have any differential diagnosis?
Sir, we can consider other treatable causes of small fiber neuropathy, sir. But however, all these will come down the line, sir, considering the chronicity
Correct,
of the
but
illness and age of incidence.
what would be your differential diagnosis? Second, third?
Yes. 1, 2, 3.
Sir, it could be Tangier and amyloid, familial amyloid neuropathy, sir. Because all these will, to start with, they will involve the small fiber nerves predominantly. Subsequently, over a period of time, they will become a pansensory modality, even causing motor weakness also, sir.
So, amyloid angiopathy, then.
And Tangier's disease, sir.
Okay.
Okay. If there is no other comment, you can go ahead with the physical examination.
Yes, sir. So from history, the probable structures involved are peripheral nerves, and among peripheral nerves, it is small fiber nerves. Coming to general examination, a patient is conscious, alert, oriented to time, place, and person. Pallor is present, no icterus, cyanosis, clubbing, pedal edema, and lymphadenopathy. No neurocutaneous markers seen. Vitals, pulse 86 beats per minute, regular in rhythm, normal in volume and character, no radioradial or radiofemoral delay. Condition of arterial wall normal. All peripheral pulses are palpable equally in both sides. Blood pressure 110/70 millimeter of mercury measured in supine position in right upper arm. Blood pressure during standing position is 100/70 millimeter of mercury in measured in right upper arm. There is no significant drop in both systolic and diastolic pressure, suggesting the absence of orthostatic hypotension. Respiratory rate is 18 breaths per minute, regular and thoracoabdominal type. SpO2 is 98% in room air. Single breath count is 40. Anthropometry, her height is 156 centimeter, weight is 43 kilogram, and her BMI is 17.66. Local examination, right foot, there is great toe amputation. Right foot, there is great toe amputation, and second toe, there is loss of nail and irregular scars present over the undersurface of the right leg. In left foot, the left foot seems swollen. The deformity of toes is present as mentioned in this history, like deviation of toes towards the right leg. Overlying skin hyperpigmentation can be seen in both legs, more on the left than right side. There is dryness present and loss of hair present below the knee, and it is not warmth or tender on examination. Irregular bony feeling on palpation, and then 1x1 ulcer over plantar aspect of foot is present, and a serious discharge is also present. So this picture is showing the dryness of skin and loss of hair below the knee level, and this is showing the right foot having loss of great toe and loss of nail over the second toe in right leg, and left leg also showing swollen, hyperpigmented, dry skin with deformed toes. Examination of nervous system. Higher mental function is MMSE 30 out of 30. Her attention is normal, memory is normal, language is normal, and speech is normal. Cranial nerve examination in detail, it is normal, has no significant findings, so I'm skipping those slides. Motor system examination, inspection, no involuntary movements, hypertrophy, wasting, winking of scapula, and straight leg raising test is negative. Bulk on measurement, there is no gross deformity seen, abnormality seen. Tone, upper limbs is normal in both sides. Lower limbs, there is increased adductor tone. Power, neck power is 5/5, trunk is normal, and upper limb power across all joints to all range of movements is 5/5, including finger grip, which is 100%. In lower limb, again, proximal hip joint, all range of movements is 5/5, knee 5/5 to all range of movements. Great toe, ankle dorsiflexion, plantiflexion is also 5/5. Toe grip could not be assessed as there is deformity and amputation of toes. So this is the video of the patient showing only positive findings. So sensory system examination, crude touch is decreased below distal 1/3 of leg, pain absent below distal 1/3 of leg, temperature absent below distal 1/3 of leg bilaterally, vibration sense is normal, joint sense and position sense are normal, Romberg is negative, cortical sensations are normal in upper limbs and not done in lower limbs due to absence of primary modalities of sensation. And coming to reflexes, the upper limb reflexes are normally elicitable, and we don't have any upper motor neuron reflex evidence in upper limbs. In knee and ankle are brisk, cross detector is present, and ankle clonus is present. Superficial reflex, abdominal reflex is present, and plantar is extensor bilaterally. Cerebellum is insignificant. Autonomic nervous system examination, no resting tachycardia, orthostatic hypotension absent as mentioned during general examination. Isometric hand grip test, BP rise was more than 16 millimeter mercury, suggesting no involvement of autonomic nervous system examination, and peripheral nerves are not thickened. No features suggestive of extrapyramidal system. Gait is normal. Cranium and spine, no local tenderness. Signs of meningeal irritation is absent. Other system examination, no significant findings are present. Summary, after examination, there were features suggestive of bilateral Charcot joint, left more than right, bilateral foot ulcers, dry skin, hyperpigmentation, loss of hair below knee, normal vitals, normal higher mental functions, normal cranial nerve examination, increased adductor tone, bilateral exaggerated lower limb deep tendon reflexes with ankle clonus and extensor plantar, with reduced touch and absent pain and temperature sensation below distal 1/3 of leg, with normal cerebellar, bowel bladder, and cardiac autonomic functions, extrapyramidal system without nerve thickening and raised ICT features. Sir, shall we proceed with the subsequent slides, sir?
Yes, proceed. Proceed.
Sir, from history and examination, it is evident that peripheral nerves are involved and predominantly small fibers are involved, and that too in a symmetrical fashion.
So what about the general examination tonsils? You suggested about the tanges. What was the was there any yellow tonsils?
Sir, no, sir. There was no yellow tonsils in this examination, sir.
Any hepatosplenomegaly?
No, sir. Other system examination is normal, sir.
Proceed.
Yes. From examination, we have added findings of bilateral pyramidal signs in lower limbs. So probably involvement of bilateral corticospinal tract is added from examination, sir, at the end of examination.
Yes, what is your conclusion?
Sir, my first provisional diagnosis would be a chronic progressive distal symmetrical small fiber neuropathy with autonomic and bipyramidal involvement. Again, probably HSAM, sir. That's my first provisional diagnosis, sir.
What are
And,
the points? What are the points in your autonomic?
Sir, we have loss of hair and dryness of legs below the bilateral leg below knee, sir. That is favoring autonomic involvement, sir.
Okay. Proceed.
Yes, sir. Yes, sir. Other differential diagnosis I would consider is intramedullary lesion because of presence of bilateral pyramidal signs after examination. Then leprosy, a treatable entity which can cause painless ulcers with mutilations. Again, amyloid tangier, as described, can cause a small fiber neuropathy and autonomic neuropathy, and extreme cases can even cause mutilations. And HMSN type 2B can cause painless ulcers, but usually I have kept down the order because this will have prominent motor involvement. But only because of the presence of painless ulcers and loss of sensations, I still considered HMSN type 2B as a differential diagnosis, but however, last down the lines.
Among the 5 differential diagnoses you have listed,
Yes, sir.
which one of them could be associated with pyramidal signs, bilateral?
Sir, among all, only intramedullary lesions can have
Yes.
associated bipyramidal signs, sir.
Yeah, that's the only one amongst the 5 which you mentioned.
Yes, sir. Yes, sir.
So, considering intramedullary lesions, what intramedullary lesions cause this mutilation?
Yes, sir. Sir, serines which is present in the lower cord can cause dissociative sensory loss with absent pain and temperature sensation with subsequent painless ulcers, and subsequently the bipyramidal involvement also, sir. But again, in such case, usually we will also have a lower motor neuron involvement and wasting and atrophy also, sir. But we don't find any such wasting or prominent motor symptoms in this case, sir.
Yes.
Yes. Then proceed for
So,
investigation.
continue.
Yes, sir. Sir, we have investigated the patient in following lines. Complete blood count showed decreased hemoglobin 6.9, MCV 66.5, and peripheral smear microcytic hypochromic anemia. Renal function test and electrolytes are insignificant. Liver function test is insignificant. Viral markers, HBsAg, anti-HCV, HIV, VDRL, all are negative. And others like ESR 60, complement CRP is 1.2, iron 28, ferritin 11.7. So probably the anemia is related to iron deficiency at this point of time. Vitamin B12 is 443, which is normal. Other investigations,
Ramanan,
is normal. Sir, yes, sir.
Ramanan,
Yes, sir.
one sort of a clarification.
Yes, sir.
Ankle jerks were diminished, am I right?
Sir, it is brisk, sir. At least 2+ we could say, sir.
No, ankle jerks were brisk.
Yes, sir.
Okay, continue.
Yes, sir. CT bilateral ankle joint. There are soft tissue opacities with multiple small calcification, tibiotalar subluxation, erosions over anterior margin of talus, medial aspect of navicular bone, base of first metatarsal, calcaneum, cuboid, and pathological fracture in third metatarsal. Phalanges are absent in second and first two. ECG, 2D echo, ultrasound abdomen, ultrasound arterial and venous Doppler of both lower limbs, ophthalmology screening, ENT screening, or were insignificant. Dermatology evaluation was also done. No hypopigmented skin patches, no nerve thickening, and split skin smear also is negative.
You only suggested tangent. Why don't you do a lipid profile? You only suggested the tangiers as a DD. Then why not
Yes,
you
sir.
include a lipid profile in the simple investigations?
Sir, after examination, tangiers went way behind, sir. So We did not investigate in those lines, sir. Because
Okay,
the
thank you.
presence of bipyramidal signs, sir.
Okay.
Yes, sir. Nerve
Can
conduction
we have
study.
two diseases? One HS, hereditary sensory and autonomic neuropathy, and another spinal cord lesion, compressive myelopathy, or can we have two lesions?
Yes, sir, possible, sir. We have done MRI to rule out cord lesions, sir.
Okay.
Yes, sir. Motor nerve conduction study. Upper limbs are normal. Right peroneal is not obtained. Right tibial is normal. Left peroneal and left tibial is not done because of technical difficulties as patient had Charcot's joint. Sensory nerve conduction study. Upper limbs are normal and both right sural and left sural is not obtained. F-wave, upper limbs are normal, right peroneal is not obtained and the left peroneal is not done, right tibial, sorry, sir, left tibial is not done and the right tibial values. I made a mistake in this slide, sir. SSR, bilateral upper limbs obtained, bilateral lower limbs not obtained, suggestive of small fiber neuropathy. Tilt table test did not had any significant drop in blood pressure. MRI dorsolateral spine with whole spine screening was done and it is normal. So lastly, we proceeded with genetic study.
MRI
Before,
brain was done.
sir, MRI brain screening was done, sir.
Okay.
Yes, sir.
Now, at this point, how do you explain the human science?
Autosomal dominant, the rest all other types are autosomal recessive. Regarding incidence, HSAN is usually disease onset of second to fourth decade and second.
You are not audible.
Sir,
Close your mic.
hello? Hello?
Come closer to the mic.
Sir, am I audible now, sir?
Yes.
Sir, with respect to incidence, HSAN2 is first decade to second decade in onset, and all other three are usually congenital at onset, sir. These are the genes associated with the subtypes of HSAN, the autonomic nervous system findings can be limited only to hypohidrosis in HSAN1, and there can be minimal autonomic nervous system involvement in HSAN2, whereas HSAN3, which is familial dysautonomia or IVD syndrome, has a profound autonomic involvement. And the fourth type and fifth type usually have lesser autonomic involvement. And higher mental function wise, cognitive deficits can be present in HSAN1, HSAN3, and HSAN4. And spastic paraparesis has been reported in HSAN1 and HSAN2 types. However, this is a classical description of HSAN types as per Dyke and Ota. Now that genetics has come into picture, the number of classification has gone more than 5. Now currently, based on genetics, HSAN is typed from 1 to 8, and even novel genes are reported extending numbers beyond 8 also, sir. So the list pertaining to our patient had an early childhood onset, and the patient had pain, temperature, and touch sensation affected. Patient had acral ulcers, stainless fractures, and Charcot joint, and the spastic paraparesis, though no weakness was there, and the sensory loss. With this all possible thing, we strongly suspected HSAN. Among HSAN, 2 was suspected, sir. This is again similar tabular column taken from another article. But our genetic study report revealed SCN11A gene mutation, which is heterozygous, autosomal dominant inheritance, and the disease being involved is HSAN type 7, sir. So looking into literature regarding HSAN 7 type, This is taken from OMIM, which is Online Mendelian Inheritance for Men. It can involve abdomen, like presenting as gastrointestinal dysfunction, diarrhea, constipation. Skeletal patient can have painless fractures. Skin, nails, and hair can have hyperhidrosis, slow healing wounds due to painless injuries, and self-injuries, pruritus. Muscle and soft tissues, there can be muscle weakness, which is mild. Coming to neurologic, it can involve both central nervous system and the peripheral nervous system. In central nervous system, delayed motor development, which is also again mild, dystonic posturing in some patients, autonomic dysfunctions. And coming to peripheral nervous system, there can be insensitivity to pain and inability to feel pain. Among these features, our patient had painless fractures, slow healing wounds due to painless injuries, self-injuries, insensitivity to pain, and inability to feel pain. The presence of UMN involvement has not been described with HSAN7 subtype. Also, further literature search revealed a novel, again, SCN11A mutation, which is a mutation involving, which is also mutation involved in HSAN7. But these patients had a new clinical phenotype, like in the form of no pain and no tears. So they have published this sisters as a HSAN novel variant, which is type 9. So conclusion, our patient, in addition to above features, also had bilateral pyramidal signs, which has not been previously reported in association with HSAN7. However, spastic paraparesis has been previously reported in association with HSAN1 and 2 subtypes. This suggests an expanding clinical spectrum of HSAN and its subtypes. More case studies in future would expand the clinical spectrum and its subtypes and better understanding of the disease.
Bipyramidal signs mentioned in HMSN paraparesis or HSAN paraparesis?
The HSAN 1 and 2, sir. HMSN doesn't have any reports showing bipyramidal signs, sir.
HMSN la bipyramidal kadayada, paraparesis kadayada.
So HMSN has. I mean, we are talking about HSAN.
I know. I'm asking. See, on the HSAN on the slide podangla, they would have mentioned absent reflexes. And the HSAN slide podanga, that's coming up. HSAN 2 la enna potrukku, DTS absent.
Yes, sir. So, but it also can have spastic paraparesis with the distal weakness clinical phenotype also.
Correct. Distal paraparesis with distal weakness. Paraparesis.
Yes.
Whether there is a difference between tone and reflexes, I don't know. It's not mentioned. And distal weakness, we'll have to dig in further and find out.
But the patient clearly had ankle clonus, brisk knee jerk, ankle jerk, and cross adductor was present.
Correct, sir. Correct. Absolutely correct.
So,
absolutely correct.
So the question is, sir, this is a case. I mean, the case of HSAN with bipyramidal signs in the lower limbs is if at all seen, it's usually type 2.
Sorry, not audible, Suresh.
Sir, if at all in any HSAN bipyramidal signs are seen, it is in HSAN type 2, sir. But in this case, we had a mutation for HSAN7.
Correct, agreed.
Bipyramidal signs, and which has been never reported, sir. So that's what a classic case with a twist.
Understood. But well, we do not have the genetic study to confirm it all. That's kuda unknown significance as usual.
No, if it is of unknown significance, we have to correlate with the phenotype, sir.
Correct. And
we had a phenotypical correlation, sir.
Phenotypical correlation of HSAN2 or HSAN7?
No, since the gene is for HSAN7, we thought it's HSAN7.
Other phenotypic correlation?
Sir, in HSAN7, we don't have a strong phenotypic correlation, sir. Spastic paraparesis, upper motor neuron involvement is not reported in HSAN.
Not mentioned, yes.
Yes, sir. Sir, so with this only, we have a question, sir. Now that this case report, with the novel SCN11A mutation. The gene mutation is SCN11A, sir, but they have come up with a newer type 9, sir. So now that we have a similar SCN11A mutation with a different phenotype of having absent pain and temperature sensation with painless ulcers, also with bipyramidal signs, should we call this as a, again, should we give a newer number for this, or we should add subtypes because it is we should add subtypes in type 2, sir, because subtype 2 has so many other mutations like WNK1, FAM134B, IGF1A, SCN9A, of which FAM134B is only mainly associated with spastic paraparesis component. And they term this as HSAN type 2B, sir. So now that SCN11A has a similar clinical phenotype which is correlating with HSAN2, should we add a comma here and put it as HSAN2E, or we should put a comma in HSAN7 clinical features that upper motor neuron involvement is also possible in HSAN7, or should we add a new number is actually a question that has to be discussed, sir.
So day is going to come when we are going to identify the disorders by genotype, not by phenotype. We probably in future we are going to call it HSAN with SCN11A gene abnormality. So future is going to name the diseases with the gene itself. That because we are finding a lot of controversies between genotypes and phenotypes. Future, I think we will be known by the diseases will be known by the genes there. So the clinical discussion will not have a much role in future. So we'll call it by the gene. So numbering may not be important. I think in future.
So the diagnosis
HSAN with the SCN11A gene. So we'll call it HSAN Suresh type.
Sir, the diagnosis can be named by gene, sir, but the technically it should be clinical phenotype and then genotype, sir. If at all, I mean, that's a clinical discussion, right, sir? Of course, if everything can be genetic, then it's become, for all the cases, you have to do genetic.
Technically, we have to rule out treatable diseases like a spinal cord.
So you're very fast.
No, we'll call it HSAN Suresh.
No, so we'll call Chitramulam, sir.
Right.
Okay. Yes. If there is no more comment, we'll go. Hello?
So what do we do now? How do we sort out?
Genetic confirmation.
Yeah, the genetic confirmation is equivocal.
That is why.
So that is why, how do we take it forward?
My point is, the ESR is raised, ferritin is increased. Both are the acute phase reactants wherein there is a sign of inflammation. Why not? It is antibody mediated problem.
No, the inflammation may be secondary to the ulcers getting infected.
CNS
Infected ulcers in lower limb.
CNS inflammation. This can be.
Limb ulcers get.
Why not? It is a CNS inflammation. Before we are branding it to the genetic cause, the treatable cause includes the antibody-mediated inflammatory disease. So why not we think of an inflammation in this case? That you can confirm it by giving a steroid. At least will give some improvement. Steroid. Then you can give the antibodies. That is you can manage with the other confirmatory evidences.
Suresh.
Yes, sir.
Will I'm speculating.
Yes, sir.
Will a biopsy of the nerve help? And could you submit that to NIMHANS and ask Professor Nalini as to her opinion with these features?
Yes, sir. I mean, we'll plan, sir. We'll plan a nerve biopsy. Yes, sir. We'll do that, sir.
Okay, thank you. And you should ask an opinion from a peripheral nerve person. I think Nalini is the only nerve person there, muscle and nerve probably.
Yes, sir. Sure, sir.
Okay, if there is no more questions or opinion, we'll go to the next case. Thank you, Dr. Ramanan, for a good case and good presentation. We'll go on to the next case by Dr. A. Dorairaj.
Thank you, sir. Thank you, sir.
It was a good
Yes, sir.
presentation
Yes.
and an interesting case. Yes.
A rare case of, please go ahead with the Duraraj.
Yes, sir. Good afternoon, sir. I'm sharing my screens. Good afternoon to all. I am Dr. Duraraj, postgraduate from Department of Neurology, Indira Gandhi Government General Hospital and Postgraduate Institute. Today I am presenting a case. A 9-year-old girl studying in 3rd standard, residing in Puducherry. The information is given by her mother. The reliability is good. The chief complaint: the patient was brought by her mother with the complaints of unsteadiness with the frequent falls since she started walking. That is from the 1 year of age. History of presenting illness: is a 9-year-old girl born out of 3rd-degree consanguineous marriage with a normal development since 1 year of age. The mother noticed there is unsteadiness while standing whenever she attempted to stand without support. Initially, mother thought it was normal for her age, but when comparing with her elder daughter, mother felt her walking was not normal till after that 1 year of age. And she also felt it was gradually progressive. Later, from 15 months of age, the baby was able to stand without support, but unsteadiness was persisted, leading to frequent falls while standing as well as walking. When she started going to school, her teacher noticed difficulty walking in straight line during school assembly. And mother also noticed she has a tendency to sway on both sides, which was aggravated while walking in a narrow path, turning and while walking and running with the same age group students. And she also had frequent falls, especially when she fell with a mild push. History of difficulty in standing from squatting posture in the form of tremulousness of body, which has made her to fall. And also she has unsteadiness was aggravated while wearing the pants with standing on one leg. And there is no history of difficulty in standing from sitting in the chair, and no history of difficulty in initiating the walk or sudden stopping while walking. And mother didn't notice any worsening of unsteadiness or falls while washing her face or nighttime. To avoid falls, she started holding hands by the bystanders or side rails while walking, and she started reducing the fastness of the walking. Falls were not associated with any loss of consciousness, tripping of toes, buckling of knees, or any blurring of vision, or any palpitation, lightheadedness, or any involuntary movements. History of presenting illness: the history of smearing of food present over the face, which was increased during approaching the hands near the mouth. And there is a history of tremulousness of distal hand while buttoning the dress and reaching the object. And history of poor handwriting due to shaking of her hands, and history of head nodding present, which was more prominent while walking and sitting and disappears on supine position. There is a history of difficulty in negotiating foot into the slippers, so the patient uses her hands to support while wearing. It was associated with the aware slippage of slippers occasionally, and not associated with any cotton wool sensation, loss of sensation, burning sensation, or any pins and needles sensation, and no history of any stirring of speech, looseness or tightness of limbs, or oscillopsia. And patient was able to perceive the smell, able to see distant and near objects, perceive colors, no history of any double vision, drooping of eyelids, able to perceive touch pain, temperature sensation over the face, no history of any angle of mouth deviation, no history of vertigo, tinnitus, hearing difficulties, no history of any dysarthria, dysphagia, nasal intonation of voice, no history of difficulty in shrugging shoulder, turning neck side to sides, unable to protrude the tongue and manipulate the foot side to side. And no history of any weakness of limbs or thinning of limbs, and able to perceive cloth, mosquito bite, and hot and cold water. No history of bladder bowel disturbances, no history of memory disturbances or speech disturbances, and no history of any headache, seizure, or altered sensorium. No history of any behavioral disturbances, and no inappropriate cry or laughter, no history of back pain or neck pain, no history of recurrent fever, rashes, joint pain, chronic diarrhea, photosensitivity, oral ulcers, and no history of any fluctuation of symptoms related to the food intake, no history of loss of weight or appetite, no history of ear discharge, ear pain, throat pain, or nasal discharge, and no history of any trauma. And past history, there is no history of any recurrent respiratory infection, bronchial asthma, tuberculosis, any cardiac disease, thyroid disease, or any diabetes mellitus, and no history of any childhood trauma. Her antenatal history, birth history, and postnatal history are now significant, and the developmental milestones are normal up to the age, except there is unsteadiness in the walking. And personal history, she takes mixed diet, and she is sleeping and appetite is normal, socially mingles with the parents, and parents with the third-degree consanguineous marriage. This is a pedigree chart showing the mother and father who are related paternally and maternally. And menstrual history, no maternal maternity. Drug history, there is no history of prolonged treatment. Coming to summary, a 9-year-old girl with a normal prenatal, birth, postnatal, and developmental and immunization history came with insidious onset, gradually progressive, unsteadiness while standing as well as walking, with the frequent falls, even with a mild push. It started when she started walking, and there is a spillage of food while eating, clumsiness of hand while reaching the objects, and poor handwriting, history of head nodding, all the above symptoms affecting her activities of daily living. And it was not associated with the aggravation during eye closure, cotton wool sensation, speech disturbances, vomiting, vertigo, and not associated with the involvement of higher mental function, cranial nerve, motor, weakness, sensory, bladder bowel disturbances, or any extrapersonal features. And it was associated with, not associated with any past personal history, except there is a third-degree consanguineous marriage in her parents. Sir.
You have mentioned it, but clarification. She does not
Yes,
have
sir.
dysarthria.
Yes, sir, no dysarthria, no speech disturbances.
Okay.
Sir. From the history and summary, the structures probably involved are cerebellar vermis because of the involvement of the ataxia whenever she stands, and also during the walking, and also there is a head nodding. So, yes, I suspected cerebellar vermis involvement and cerebellar hemispheres involvement because of the tremulousness of hand, especially increased while reaching the objects, and also affecting her handwriting. So the vermis and cerebellar bilateral cerebellar hemispheres are involved, and the onset is from the 1 year to 2 years of age, which was present for more than 7 years. At present, the patient's age is 9 years. It started from 1 year till now. It's slowly progressive. It's present for long duration. It's a bilateral involvement. So the probable provisional diagnosis based on the history, early onset, chronic, progressive, symmetrical, transcerebellar ataxias.
What about eye movements?
Sir, from history wise, there is no history of any double vision or any change, turning of heads first before any voice sounds, or is there any abnormal visual symptoms, sir?
Any history suggestive of eye movements? Anybody has noticed that her eyes are wobbling?
No, sir.
She was able to fix the object?
Yes, sir. Yes, he was able to fix objects and able to listen and able to make eye contact properly.
How can you say it is pancerebellar?
Yes, sir.
Okay,
Midline
doctor.
and hemispheres.
Sir?
Midline and hemispheres.
Yes, sir. Yes, sir. Midline and hemispheric involvements.
Okay, doctor, you have given the anatomical lesion and pathological lesion. What is the probable etiological lesion?
Sir, because of the early onset with the chronic progressive over a period of 7 years, a probable differential diagnosis. First, I want to rule out a craniovertebral junction anomaly. Even though the craniovertebral junction anomaly is an asymmetrical presentation with lower cranial involvement and associated sympathetic Horner syndrome, I want to rule out the structural anomaly, which is a treatable entity, followed by inherited causes, sir. The inherited causes probably the autosomal recessive cerebellar ataxias, which includes the pathology involving the mitochondrial disorders, mitochondrial pathology such as Friedreich's ataxia, coenzyme Q deficiency, or any DNA repair mechanism such as ataxia telangiectasia, ataxia with oculomotor apraxia, spinocerebellar ataxia with axon neuropathy, and mitochondrial recessive ataxia syndromes, and ataxia, autosomal recessive ataxia with metabolic defects such as vitamin A deficiency associated ataxia, A beta lipoproteinemia, cerebrotendinous xanthomatosis, and ataxia associated with protein folding defects such as Marinesco-Sjogren syndrome, autosomal recessive spastic ataxia of Charles-Sagini, Refsum disease, and other metabolic diseases such as the Niemann-Pick disease and infantile onset spinocerebellar ataxia.
Why you have left Refsum's?
Sir, I included in a protein folding defects Refsum disease I included.
It's a long list.
Yes, sir. I included all the inherited causes because from history wise we are not able to differentiate, sir.
Xeroderma pigmentosum you have included anywhere?
Sir, history wise there is no history.
DNA repair.
Yes.
There's no learning disability.
Sir, she is studying now 3rd standard, sir. She is going schools regularly and there is no learning disabilities in her patients.
She was able to. Now it's very difficult to get now in the high schools and all. They all give pass. Now very difficult to get a history like that because even if you say 4 + 3 is 9,
yes,
you are supposed to give us a right and you are not supposed to blame the student and you are not supposed to inform the parents.
Yes, sir.
Did the parents notice that her schooling is not proper? Because when she is having a difficulty in writing,
yes, sir.
how will she be able to? And what about his speech? Speech is also disorder.
Sir,
No disorder.
yes, sir. Speech is not involved, sir. She is speaking normally.
How can her be language, her education be normal?
Sir, her speech is normal and she is now studying 3rd standard, sir.
So studying 3rd standard is different. See,
yes,
they could have just sent her to 3rd standard. Does she
okay,
have the 3rd standard level of educational status?
Okay.
Has she compared herself to the relative's child that her learning? Because why I'm asking is that
yes,
it may be you think it's an acquired disease, but it has started from the age of 4 years, 5 years. She has started walking at the age of 1.5 years.
yes.
Even there is a mild delay. So there is a possibility for congenital disorder also. And the genetic disorder coming a little late is something which is difficult. No, something must give us a clue that
Yes,
it has started from birth.
Okay.
Do you think it's an acquired disorder or do you think it's a infantile onset spinocerebellar ataxia?
Sir, acquired disorder is less probable, sir, because it is there for more than 7 years. There is no fluctuation.
Yeah, it looks like a disorder in childhood.
Correct.
Yes, sir. Yes, sir.
Since birth, yeah. That is why I asked. So you must get a history of perinatal problem and how she crawled, how she started having. Even there's a slight delay. Some head controllers, there will be a wobbling and a headache. Even if it is from 3 months to the 4th month or 5th month. Even she started walking at the age of 1.5 years, you said, isn't it?
Yeah.
Even while she started walking, she started having ataxia.
Yes, sir. Yes, sir.
So it must be a congenital problem.
Can we think about structural disorders, sir? Like dysgenesis of cerebellum.
Sorry?
Yeah.
Sir, Chitramalam, என்ன சொல்றீங்க?
Structural disorders, sir.
Oh.
Cerebellar dysgenesis.
Yeah, structural disorder since birth. Yeah.
Yes, sir. Jubert's.
So then it becomes a congenital disorder. It's not an acquired disorder.
Yes, sir. Congenital.
Sir, mother, I inquired about the mother, sir. She told there is a head holding and neck holding and a grasp and sitting without support, sitting with support. That and all, she was almost the same as what her sister did, sir. That's why mother told it's up to 1 year. She didn't find anything abnormal in her child.
Most of the time, mothers will never accept the child delayed. And most of the time, it's very difficult. Getting a history of developmental milestones is very difficult. And most of the time, no, they will not even remember when she had head control.
Yes, sir. Yes.
So you have to be you have to take that history with a pinch of salt.
Okay. Yes.
The chair says continue.
Yes, continue. Yes.
Yes, sir. Going to general system examination, patient is conscious, oriented, cooperative, and a height is 125 centimeter, weight 19 kg, and head circumference 52 centimeter, and height like ratio is 9.7. And head to foot examination, her hair, skin, and nails appears normal, no dysmorphic facies, no skeletal deformities, and no telangiectasia or cataract, and no tendinopathies. And vital system examination, pulse 92 per minute, regular rhythm, normal volume character, no radial or radiofemoral delay, all peripheral pulses are filled. And blood pressure 92 per 62, measured in supine position. In upper arm, there is no posture drop in BP, and respirated and SpO2 normal. And her attention, memory, language, and speech, everything was normal. And cranial nerve examination, her cranial nerves, actually the cranial nerve examination 1, 2 normal, and 3, 4, 6, there is no ptosis and extraocular movements are full. And there is a bilateral gaze evoked horizontal coast nystagmus present, which is not present in the primary position, and it was appears without any latency and it's not fatigable. And no diplopia, and the pupils appears normal 3 centimeter circumference shift, and all other cranial examination was normal. And motor system examination, inspection, no voluntary movements, no involuntary movements, no hypertrophy or wasting, and bulk bilateral symmetrical, tone appears normal, and power bilateral upper limb and lower limb, so 5x5 involving the all joints, all movements, finger grip 100%, and toe grip between 80% in bilateral lower limb, and superficial reflexes are present, and plantar was bilateral flexor, and deep tendon reflexes in upper limb biceps, triceps, supinator are present, and knee jerk and ankle jerk were bilateral brisk. And sensory system examination, touch, pain, temperature was normally perceived, and vibration perceived normally, joint sense and position sense normal, Rombox was positive, and the tactile characterization, 2-point discrimination, graphesthesia, and stereognosis normal. And cerebral system examination, there is a head tremor present, which is predominantly in the antero-posterior direction. And I already explained the nystagmus, and there is no abnormality in sockets or pursuits. Finger nose test bilaterally impaired, intentional tremor present, dysadicokinesia present, and rebound phenomena is lost. Heel knee shin test impaired, and gait was impaired. It's an ataxic gait. I'll show the videos. There's only a gaze evoked nystagmus present. And we can notice the head nodding and gait of the patient. Patient has a swaying to both sides, and also she is not able to do the tandem walkings. So this is about the cerebral system examination. And gait, there is no difficulty in rising from the sitting to the ground, which is associated with the tremulousness only. And there is a wide-based stance. The initiation of gait was normal, and the stride length and step length are variable, and a tendency to sway on both sides. Tandem walking was impaired, and cadence was 114 per minute. And autonomic nervous system, peripheral nerves were not thickened, and spine and cranium normal. And Abdomen, there is no organomegaly, respiratory system normal, and cardiovascular system, S1, S2 here, no added sounds. Along with the history, in the examination, in general system and vital signs are normal. There is no additional extracutaneous markers suggestive of any ataxic syndrome. And on cerebral system examination, which shows head nodding, impaired finger nose test, dysarthrokinesia, intentional tremor, positive rebound, and gait ataxias. The same structures involved cerebellar hemisphere and vermis only was there. There is no additional structures detected in the examination findings.
Have you recorded her handwriting?
Sir, sorry, sir, I didn't write the handwritings.
Ask her to draw an Archimedes circle, and then you should see the serial handwriting. Previous year, what is the handwriting like? What about a school? What do they say? And whether mother has noticed her handwriting has worsened. Because you say she has got a gross intentional tremor.
Yes, sir. Yes, sir.
That means definitely her handwriting would have been affected.
Yes, sir.
So recording of handwriting and cerebellar system of the upper limbs is very important. That too in child. I always say in pediatric neurology examination, the examining doctor should always have a pen and a paper.
Okay, sir.
And the intentional tremor video coming up?
Yes, sir.
She has, but no gross and சொல்ல முடியாது. Right. Okay.
So can I play it again, sir?
Right. Okay, you continue. No need.
Yes, sir. Yes,
Continue.
okay.
Continue.
Yes, sir. So we already discussed the differential diagnosis. From the examinations, we are ruled out some of the differential diagnosis based on the examination findings. Because of symmetrical involvement and no bladder bowel and criminal signs or any Horner syndrome, and we ruled out craniovertebral junction anomaly. And Friedreich's ataxia, which is more common 5 to 15 years of age, associated with absent lower limb reflexes and dysarthria. And ataxia telangiectasia, which was associated with telangiectasia. And ataxia with oculomotor apraxia. In this patient, there is no oculomotor apraxia. And there is no tendon xanthomas. And there is no associated optic neuropathy or any ichthyosis, and there is no organomegaly. We ruled out some of the differential diagnosis, sir. Can I move to investigation, sir?
What is your final conclusion?
Sir, from the history, we suspecting the autosomal recessive cerebellar ataxia of inherited in nature, which may be associated with which starts from the 1 year of age. Can be either
with retained reflexes.
Yes, sir. Yes, sir. Retained reflexes.
The reflex, it is ADCA, autosomal dominant cerebellar ataxia with retained reflexes. That's a different, because Friedreich's cannot come there at all.
Yes, sir.
Friedreich's is notorious to produce absent reflexes.
Yes.
But if reflexes are present with a similar presentation, an entity called EOCAR, sir. Early onset cerebral ataxia with retained reflexes.
And ADCA,
the degenerative types.
Anita Harding's type, that is what.
That's a EOCAR, sir.
Yeah, fine. Yeah. Good.
Okay, proceed to investigation.
Yes. So the cerebral, the normal blood count, renal function test, liver function test, vitamin B12 level, thyroid function test, viral markers, everything was normal. And chest X-ray, ECG, echo, and ultrasound abdomen, ophthalmological examination, fundus examination, ENT, everything was normal. And a motor nerve conduction studies, which shows there is a delayed latency with the nerve conduction study decreased in bilateral median, bilateral peroneal, and bilateral tibial nerves with decreased nerve conduction velocity in left ulnar motor conduction studies. And sensory nerve conduction study, none of the nerves are not stimulable, like bilateral median, bilateral ulnar, and bilateral sural nerves are not stimulatable. And the FAs are normal in upper limb and absent in lower limb. So the nerve conduction studies use report of sensory motor combined involvement with axonal and demyelinating pattern mixed neuropathies. From history and examination, there's a early onset chronic pancerebellar ataxia with a nerve conduction study supportive of mixed neuropathies, sir. So which narrowed down the further diagnosis of Friedreich's ataxia with retained reflexes, vitamin E deficiency related disorder, Refsum disease, mitochondrial disorders, and autosomal recessive spastic ataxia of Charles-Fox-Sagoni, sir. And we did the MRI. The MRI T1 axial images shows cerebellar vermis atrophy with hemispherical atrophy. In T2 also shows the cerebellar vermis atrophy with hemispheric atrophy. In a T2 axial images shows there is an hypo-intense stripes in the pons, which is a tigroid appearance, which is a MRI biomarker for autosomal recessive spastic ataxia of Charles-Fox-Sagoni. It is an autosomal recessive disease characterized by peripheral neuropathy, cerebellar ataxia, and spasticity due to the mutation involving the SAX gene. In our patient had a cerebellar ataxia clinically, which is an infantile onset with peripheral neuropathy of mixed pattern, which is commonly seen in Ersach's disease without spasticity. So we proceeded to the genetic study, which shows there is a SAX gene mutation. It's a homozygous pattern involving the SACS genes.
Okay. Any opinion or any comment from the participants?
Clinically, peripheral neuropathy with retained reflexes is very difficult to swallow. That too mixed
Yes.
neuropathy, both motor and sensory are affected.
Yes, sir.
And which neuropathy reflexes will be retained?
But Ersach's
Sir,
has that specific features, Ersach.
yes, sir.
No, idea of presenting this case is this patient presented as like early onset cerebral ataxia or a congenital ataxia. But the most important differentiating feature clinically was the patient did not have any pyramidal signs. Though the diagnosis is spastic ataxia of Charlevoix-Shagwani type. So this patient clinically did not have spasticity, but genetically it fits into Ersach's. So that is the most important point which we felt in this case, sir. And another thing which we wanted to highlight in this case was the MRI biomarker. So if you have an MRI biomarker of these pontine transverse stripes, and you can go for a single gene testing. So if you find this, you do a single gene testing, and you do not go for a full ataxia panel.
And again, you can avoid mitochondrial genes also. Otherwise, we will include mitochondrial exome, whole exome plus mitochondrial genome we need not do. We can simply go for a whole exome or a clinical exome.
Yes, sir. So idea is whenever you get an early onset cerebellar ataxia to look for MRI biomarker as well as laboratory biomarkers. And idea of presenting this case also to highlight these 2 points, sir.
Excellent.
Sir, in
Very good,
institute, we
CTS,
presented
very
an
good.
Ersach, sir. Professor VN,
Sir?
we presented an Ersach. Sundar presented an Ersach, I think, sir, in the institute.
அதுக்கப்புறம் நிறைய இருந்திருக்கு.
Okay.
அப்பப்ப கேஸ் வருது.
Sorry.
Especially instituteல.
Chitramalam sir present பண்ணாத கேஸே இல்ல சார்.
There you are.
Okay. If there is no more comment, we can go to the next case.
Yes, sir.
Thank you, sir.
Case Dr. Devi, consultant neurologist, Indira Gandhi Government General Hospital. Double hit in a family. Dr. Devi.
Sir, good morning, sir. I'll share my screen, sir.
Oh, yes. Proceed.
Good morning, sir. Now I am going to present a case of double hit in a single family. Sir, am I audible, sir?
Yes, yes. Proceed.
Yes, sir. So this patient, Master D, 5-year-old male child, studying first standard, hailing from Puducherry, presented with complaints of difficulty in climbing stairs since 1.5 years of age, difficulty in walking since 1.5 years of age, swelling of calf muscles since 2 years of age, difficulty in running since 3 years of age. History of present illness. Master D was sixth born child of a third-degree consanguineous marriage. He was born at term by normal vaginal delivery in a private hospital. He did not have any significant perinatal history. He attained all his developmental milestones appropriate to his age. At 1.5 years of age, mother noticed difficulty in climbing stairs by holding bystanders' hands or rails. She also noticed difficulty in standing from squatting position, such as he used to stand with support of his mother. She also noticed slippage of sandals from his foot. Since then, he wears sandals with strap model. At 1.5 years of age, mother also noticed he used to fall frequently, associated with buckling of knees. These falls were associated with trivial trauma to legs and were not associated with loss of consciousness, involuntary movements, tongue bite, frothing, or urinary incontinence. Currently, he falls approximately once in a month. At 2 years of age, he started to complain bilateral leg pain, predominantly over calf muscle and thigh, which was intermittent, dull aching, aggravated on playing, relieved upon taking rest. Mother noticed swelling over both calves, which is gradually increasing in size. All the above mentioned difficulties were insidious in onset, gradually progressing till date without any episodic aggravation of or cold exposure. There was no history of difficulty in mixing food, lifting up the hands above the head, lifting neck from the supine position, breathing difficulty, difficulty in swallowing food, nasal regurgitation. There was no looseness or stiffness of the limbs. There was no history of thinning of the limbs or any involuntary twitching of the limbs. There was no history suggestive of higher mental function, cranial nerve, sensory, cerebellar, or autonomic nervous system involvement. Past history not significant. He is not a known case of cardiac disease, bronchial asthma, pulmonary tuberculosis, renal disease, liver disease, connective tissue disorder, childhood malignancy. No history of any recurrent respiratory tract infection. No history of any chronic drug intake. Personal history: he takes mixed diet. No known addiction. Appetite and sleep is normal. Family history: is born out of third-degree consanguineous marriage. Sixth born child out of 7 children. He was born at full term by normal vaginal delivery. No history of any birth hypoxia, neonatal stay, or connectress. His all developmental milestones were appropriate for his age. And this is the pedigree showing his family tree. So maximum what detailed pedigree we could obtain, we had obtained. And this is the patient. The sixth born is the patient. And his father and mother had a consanguineous marriage, third-degree consanguinity. His mother's mother, his grandmother, and his mother's grandmother and his father's grandmother had married to a same husband. That is one male. He had 2 wives. The both wives were also sisters, and one wife's lineage belongs to his mother, and other wife's lineage brought up to his father. So his father and mother were also married consanguineously, and the first born child was a female child. The detailed history I'm explaining in the next few slides, but the child succumbed to an illness which was different than him. The baby had developmental regression in milestones, had myoclonic seizures, succumbed at 4 years of age. The second one was a twin pregnancy. In the twin, both were males. First twin died at 3 days of age due to respiratory difficulty. Second one lived up to 3.5 years of age. The illness was very similar to the elder sibling, which was the female child. The second one also had myoclonic seizures, developmental regression milestones. Both the kids were normal up to 1 year of age. The myoclonic seizures started at only the first year after the first birthday only it started. The third one is a IUD, which was spontaneous at 3 months of age. The fourth one is also a twin baby, but the mother says it was a twin. The scan was done at 3 months. The doctor said it is a anomalous, both are anomalous twins, and MTP was done. The fifth pregnancy was a stillborn. The baby delivered at home, stillborn at 7 months of age. The sixth one is our patient. The seventh one, that is his younger sibling, also was a male child, born normally, normal development till 1 year of age, had a very similar illness like the first female child and the second male child. That is, had myoclonic seizures and developmental regression of milestones. The younger sibling alone is alive along with our patient. So this is the detailed history which I had explained in pedigree. Only the disease illness, I will just tell a few words. The first baby, which was a female baby, after 1 year had a normal vaginal delivery, no perinatal, had a doubtful perinatal asphyxia, but at 1 year of age had multiple semiology of seizures, including myoclonic, focal clonic, GTCS. Seizures were initially associated with febrile illness, later was unprovoked, treated but was refractory to anti-seizure medication. It was associated with the regression of all the achieved milestones earlier and became bedridden. The baby was not evaluated due to financial reasons, and the baby had died in sleep at the age of 4 years. The second baby also, I'm not going to repeat, had a very similar illness as the first one. This was the mother's terminology. The mother's terminology was all the babies used to be normal till the first birthday. When the first birthday, the photograph is taken, the second one had the myoclonic seizure first time when the photograph was taken for the baby. So that baby also initially was had a refractory seizures to ASM, and that baby also had regression of milestones, became bedridden. But the second one, male child, was evaluated in JIPMER, and they had given a diagnosis. They had done a genetic test. So they had given a diagnosis of progressive myoclonic epilepsy. The genetic test revealed ACTD7 mutation and also additionally DDC mutation, HNRNPU mutation. Baby died at 3.5 years of age, died in sleep. So the third one, fourth one, fifth one, we have covered already. Sixth one is our patient, and coming to the seventh baby, which is alive now. So alive baby now, born by emergency LSES, hospital delivery. This baby also had very similar illness like first one and second one. Was normal till first year, then developed multiple semiology seizures. Seizures were refractory to anti-seizure medication, then had regression of achieved milestones. This baby was also evaluated in JIPMER, and genetic test revealed myoclonic epilepsy associated with KCTD7 mutation and also 2 other mutations. One was similar to the his elder sibling, which was DDC, and the other one was a newer mutation, which is SCMA6B. So this is the younger sibling of our patient. I just told them to bring the baby so that we could examine. So the baby was fully hypotonic. It was very flaccid, not able to move all 4 limbs. I just took a photo to record the head drop. So coming to the summary, our patient is a 5-year-old male child born out of third-degree consanguineous marriage with an uneventful birth history, normal development till 1.5 years of age, presented with insidious onset, gradually progressing proximal weakness more than distal weakness of lower limbs, with bilateral leg pain, with swelling of both calves, with recurrent falls, with no history of weakness of upper limbs, truncal muscle, neck muscle, no aggravating relieving factor, no history of stiffness or thinning of limbs, no family history of similar illness, but there was a family history of a very bad obstetric history in the mother and 3 siblings, similar illness of myoclonic seizures, multiple semiology seizures, refractory seizures, and developmental milestone regression, because of which 2 siblings already succumbed to illness and 1 sibling is alive. So coming to general examination, the patient is conscious, alert, oriented, no pallor, icterocinosis, clubbing, lymphadenopathy or pedal edema. Vitals were all normal. Anthropometry was not normal. His head to foot examination revealed he had a prominent forehead, high anterior hairline, wide nasal bridge, upturned nose, and a low set ears. Sire mental function was normal, cranial nerves were normal, motor system examination, bilateral calf muscle hypertrophy was present, and valley sign or Pradhan sign was present, which is atrophy of posterior fibers of deltoid and infraspinatus with sparing of teres major, latissimus dorsi, and triceps. So his bulk was normal in both limbs, tone was also normal. On examination, he had proximal muscle weakness of upper limbs. There was no distal muscle weakness in upper limbs. And he had both proximal and distal muscle weakness in lower limbs. This is individual muscle examination chart. His reflexes, all the DTRs were present. And his superficial reflex, abdominal reflex present, and his plantar both were flexor. Gait was normal. Gover sign was absent. Sensory system was normal, cerebellar system normal, autonomic nervous system normal, peripheral nerves not thickened, cranium and spine normal. Signs of meningeal irritation was absent. Other system examination was also normal. Coming to investigation, is a complete blood count, renal function test, blood sugar were all normal. LFT showed a raised SGOT and SGPT. Serum CPK was very high, it was 15,000. Viral markers negative, thyroid function test normal, ECG normal, 2D echo normal, chest X-ray normal. EMG, we convinced the patient, but the patient was very afraid of seeing the needle. So we couldn't do a EMG. And we did a clinical exome and whole mitochondrial genome sequencing where the patient was positive for Duchenne muscular dystrophy mutation. So this since the genetic test earlier was done in the same lab, we could obtain a synopsis of all the reports of his family. So this table, this is our patient, which is DMD positive, and along with that, he also had HNRNPU gene mutation positive. His elder sibling, which was a twin born, the second born in the family, he had HNRNPU mutation, KCTD7 positive, DDC mutation positive. His younger sibling, who is alive now, has KCTD7 gene mutation positive, DDC in common with the elder sibling, and a newer mutation, CMA6B. So analysis of the case, our patient had 2 gene mutation positive, which was DMD and HNRNPU, which is heterogeneous nuclear ribonucleoprotein U type gene mutation positive. So we already know DMD is X-linked recessive. 30% of the cases can have de novo mutations. There was no history of a similar myopathy in the family or any neuromuscular disorder in the family. But still, regarding DMD is a X-linked recessive, still the mother would have been a carrier for this kind of mutation. The parents were not willing to or nor affordable to test for genetic test. And 30% of DMD can also arise as de novo mutations. Coming to HNRNPU, few points it is basically most commonly arises as a de novo mutation. It is when inherited, it passes as autosomal dominant. It is a neurodevelopmental disorder, presents with developmental delay in childhood with intellectual disability, mostly speech and language disability, can have behavioral abnormalities. Seizures are more common, refractory seizures, but the type of seizures are tonic-clonic or absence, and dysmorphic faces can be present in HNR and PU, and the dysmorphic faces are prominent forehead, high anterior hairline, upslanting palpebral fissure, broad nasal bridge, upturned nose, low set ears. Less common are other organ involvement. So in our case, though our patient had normal developmental with normal cognition and no history of seizures, he had facial dysmorphism, which is not usually a general clinical feature seen in DMD. This type of dysmorphism matches with that of HNRNPU mutation. Hence, we propose HNRNPU mutation could have contributed to the facial dysmorphism, even though other features of the disease is not manifested till now. So coming to elder sibling mutation, he had 3 positive mutations. A few points. KCTD7 mutation is an autosomal recessive kind of inheritance. Parents are generally asymptomatic carriers. So it can cause progressive myoclonic epilepsy type 3, and a variety also causes neuronal ceroid lipofuscinosis 14 type. The disease occurrence is in infancy or childhood, presents with myoclonic seizures, developmental regression, motor, cognitive decline, which our patient had. So sibling was symptomatic for KCTD7 mutation and finally succumbed to illness at 3.5 years of age. So coming to DDC mutation. DDC mutation is basically DOPA decarboxylase gene mutation. It is again autosomal recessive and parents are asymptomatic carriers. So this is basically codes for aromatic acid decarboxylase enzyme, which is AADC. It has a role in biosynthesis of dopamine epinephrine. The clinical presentation varies extensively, but the common presentation I referred into to know whether that baby had manifestations of DDC. So the common was early hypotonia, movement disorders like oculogyric crisis, dystonia, hypokinesia, developmental delay, and autonomic symptoms. So sibling A had, which is elder sibling, had history of developmental digression, but never had oculogyric crisis or movement disorders or autonomic features as per history. Hence, we propose DDC mutation might have been silent for him, but the non-expression of the mutation could still be due to the child expired at an early age. Coming to HNRNPU mutation, which the child had, we already discussed earlier about HNRNPU because that mutation is found in our patient also. By history alone, we could not differentiate whether clinical features are due to KCTD7 or associated with HNRNPU because HNRNPU also causes seizures, intellectual disability. Another drawback is that mother was not able to give correct history about facial dysmorphism. Coming to younger sibling, he had KCTD7, DDC, CMA6B. We had already discussed about KCTD7, which was present in elder one, which has a PME type of spectrum. And sibling B had history of developmental regression, but never had oculogyric crisis and autonomic. So the same reason holds good whether DDC was silent or non-expression could be the child expired at an early age. Coming to CMA6B mutation, CMA6B is mostly due to de novo mutations. If inherited, it is autosomal dominant, arises in childhood or adolescence. The manifestations ranges from developmental encephalopathy without epilepsy or developmental epileptic encephalopathy or a PME type of phenotype. So sibling B had, that is younger sibling, had CMA6B mutation, which none of his tested siblings showed positive. Since his disease phenotype was of PME spectrum, we could not still differentiate whether it was purely due to KCTD7 related or due to associated CMA6B also. So literature search we did because 3 siblings of our patient had phenotype of PME and the causative gene mutation described were rare. We looked into literature for depth of knowledge into causative genes for PME, and we have found out an article published in Genes, January 2024, Progressive Myoclonic Epilepsy, a scoping review of diagnostic, phenotypic, and therapeutic advances. There we find, apart from the well-known PME like Unverricht-Lundborg, Lafaro body, neuronal ceroid lipofuscinosis, action myoclonus renal failure, MRF, sialidosis, etc., there are upcoming category of various miscellaneous genetic PMEs. There are quite a few additional PMEs with known genetic causes. However, there are very few publications on these PMEs. This we found out in that big exhaustive list we found out. CMA6P is mentioned with very few case reports, and KCTD7 is also mentioned. So rarity of the gene mutation seen in this family, we left alone DMD because we see that on and off. HNRNPU cases reported worldwide till date is 80, DDC 261, KCTD 742, CMA 6P 35. So summary of observations are, our patient had Duchenne muscular dystrophy along with facial dysmorphism and with family history of complex consanguinity and siblings with phenotype of PME spectrum. Conclusion: the familial tree exhibits cluster of cases of phenotype and genotype of PME spectrum, bad obstetric history with silent genotypes too. The complexity of consanguinity probably contributed to different genetic mutation detected, in which a few mutations were mostly reported to occur commonly de novo. Highlight of this case is the detection of an entirely different neuraxial involvement of a muscle disorder among the phenotypes of PME spectrum. As per literature search, there are no such reports of Duchenne muscular dystrophy and PME occurring within a single family, making this case a unique one. And follow-up till date, I could do only a phone call 1 week before because patient was admitted with us 8 months back. On follow-up, younger sibling had succumbed to illness at March 2025, which photo we saw, I was holding him. Following demise of that child, mother shifted court to Chennai to stay at her mother's home for emotional support, and she is on treatment for depressive illness. Our patient is a school-going kid. Still, he goes to school, participated in August 15 Independence Day function, and had fall in the stage due to buckling of knees and broken his tooth. He is on follow-up with a pediatric neurologist in Chennai and currently on deflazacort therapy. Thank you.
Thank you, Dr. Devi, for the good and nice informative discussion on this topic, which is
Yes, sir.
very, very interesting. Now, any opinion from the participants?
No, first of all, I must congratulate the detailed presentation of this of all the cases and the family. And I am very now I am a little confused that we diagnose the patient and then fit back, look for the clinical signs rather than clinical signs and coming for the diagnosis. After the probably year of genetic testing. And once the genetic testing comes and if it fits in with, then we look for the signs for the baby and then we come to that conclusion. What is happening? What is happening to the clinical neurology? And clinically, probably the Duchenne muscular dystrophy is something which even that is atypical. And progressive myoclonic epilepsy in a family of Duchenne muscular dystrophy is something, again, which is never heard of. And probably the genetic testing and exome sequencing testing, it's making a sort of revolutionary way of thinking for our clinical neurology. As it is usually said that we should not fit in with, we should diagnose and go for the investigation. And what is happening, I don't know. The genetic testing is misleading us. Are we right in doing that, or are we looking for that, or are we getting so many mutations? What is it? I'm sorry, I don't know. Three types of differential, three types of diagnosis we have to make in 3 children of different type. And Duchenne muscular dystrophy child is living with, of course, it's typical rise in CPK, but no cardiac involvement, no mental retardation. So the whole teaching has changed now. We have to do the genetic testing even with a minimal clinical finding. After that, once the genetic testing comes, look for the further diagnosis. Is it so? Is it so? Which is what we must do now. Or why sir? I want Professor Vian to say. We are looking in the era of searching for the precision of diagnosis. Are we doing the right thing? We are getting the cases. Of course, they are all real. What we are seeing is real. And where are we going?
Sir, actually, this patient
Devi and Megan, sir, clinically, the first case, index case, we would have diagnosed as Duchenne muscular dystrophy. Clinical presentation was quite suggestive.
Yeah.
Only the family history again, it looked like a developmental epileptic encephalopathy in the siblings. So
there's one child with PME. Yeah, there's one child with PME, very classical PME, she said.
Yes.
Progressive myoclonic encephalopathy.
Yes, sir. So the clinical diagnosis would have been DMD and developmental epileptic encephalopathy in the SIBS. But then, for the genetics, we now are able to conclude which gene is abnormal, which gene is mutated, and come to a genetic diagnosis. But clinically, I think we are okay. It depends on Devi's view. How did you view it? Devi, you
Sir, actually, patient is had a clear-cut Duchenne muscular dystrophy. There is no doubt about it. But the only thing was the siblings all had a PME spectrum disorder.
And the dysmorphic faces of the child. Again, we needed a genetic for explaining the dysmorphic faces of the child.
Yes, sir. Actually, patient had Duchenne muscular dystrophy, but the facial dysmorph is truly to tell only after the gene mutation came. Then I looked into why the other gene is not getting manifested in him. Then on going into detail of that gene mutation, I found out the hallmark of that gene mutation is neurodevelopmental disorder with facial dysmorphism. Those were the hallmark features of that HNRNPU gene mutation. So then I thought, why at least some thing should have expressed in him. Then on looking into detail, I found out, okay, he has some facial dysmorphism. So it was like we had viewed the case as a Duchenne muscular dystrophy only. So clinical still holds good. The only thing which made it interesting was the history of PME type of spectrum in the siblings, sir.
So polyhill sign in Duchenne is it a pseudo polyhill or it's a real polyhill sign, value sign in Duchenne's? It's a classical sign of a facioscapulohumeral FSHD, but this is found in this child.
I think she showed valley sign.
Yes, sir. Duchenne muscular dystrophy, FSHD is polyhill sign. Duchenne muscular dystrophy has classical valley sign, sir.
No, what she showed was valley sign, not a polyhill.
Not a polyhill sign, yes.
Yeah. The idea.
What about the child's age? What did you say? The child is 5 years.
Yes, sir. At present, 5 years of age. Illness started at 1.5 years of age.
Any TA tightness, and what about her extensor digitorum brevis, which is hypertrophied? Or how does he walk? Walk on toes? So the clinical features get distorted in presence of multiple mutations. I think what I want to point out is that once the genetic testing result comes, we have to look for the other findings which have been given in the report. That is how we are now. We are in an era where we have to verify what are the things which we have missed. So clinical neurology still, as you say, holds good. But clinically, we should start suspecting a few things, which is rare. And hence, we have to look for further diagnosis. Like that, I think we must go. The clinical neurology discussion nowadays should not stop with the typical findings and look for any other atypical feature of any classical finding. I don't know.
Yes, sir.
I don't know. That's what we are doing nowadays. Most of the time, no, we are cutting our legs for the size of the cot.
Yes, sir.
But development of science is inevitable, and also development of neurology, because neurology is now developed into several fold by genetic and also immunology. That is why we have to rewrite our entire textbooks from the point of genetic and immunology.
Yeah. Genetics, immunology, and several pediatric neurology and all those things. The whole thing is that how are you going to teach the future generation about the clinical neurology, what is typical, and look for the atypical features also.
Yes. Fully agree. But more so, the problem is more so with the pediatric age group than adult, because developmental neurology is totally different.
We still do not know, because adult neurology, I mean, after that, once the genetic testing comes, the seizure disorder, everything brings back, go back to the pediatric history and then look for the genetic enzyme like that. We have started seeing in the recent econ. They presented several cases of.
But real fact is, when the person grows, the cat will be out in pediatric age itself. So adult, we are only following it. That is the thing. Pediatric neurology have got more problems in future.
Just deviating from the discussion, I just read a book. I want all the medical students to read, written by Lena Saunders. Every patient tells a story. There she says that after the invention of the death, or she even goes to the extent of the demise of clinical neurology, is natural in presence of the advanced technologies.
Clinical neurology is immortal. Actually, clinical neurology is immortal. It will never die.
So we cannot use the word demise. She has written like that.
Okay.
And she says that, I'm sorry to say this, it is not exactly demise. We have to put the clinical neurology in ICU.
Yes.
And we must further interrogate and further go into in details in clinical neurology itself.
Clinical neurology might have to be revised.
Yeah, it should be revised instead of
refined.
It's a very good book.
Is refined by these steps.
Sir, she has written 2 books, sir. Another book is called Diagnosis. Lisa Saunders. I think all the senior people should read that, and then they should give their comment one day, I think.
Thank you, Dr. Devi, Dr. Thank you all for the good discussion.
So just a minute, sir. Can I
Yes.
So I would like to, Dr. Devi needs to be appreciated for this painstaking presentation, sir.
Wonderful.
She really worked up the case and all that. Sir, from the genetic, now we move on. The next case, I just want to talk for, 10 seconds, sir. Next case, Dr. Jayshree will be presenting. It's a group of 3 cases. It's just a phenotypic presentation. We haven't done genetic for those 3 cases. Just to highlight the phenotypic heterogeneity of a single disease, sir. We'll take all 3 cases together. Can we welcome Dr. Jayshree, sir? The chair's present.
Yes.
Thank you, sir.
Welcome, Dr. Jayshree.
Good afternoon, sirs.
Yes.
Yes, sir. I'll start sharing my screen, sir. 1 second.
Okay. Show your video also.
Yes, sir. Yes, sir. Ma'am, stop share. Please give stop share, ma'am.
Yeah, where is it?
Ma'am, down icons will be there, ma'am.
Dr. Devi has to stop sharing.
Yes, sir.
Meanwhile, Paranjoti sir, in your neurology simplified textbook, please include all these
where you will unmute or start video, no, ma'am.
Yes, sir.
Many icons will be there, ma'am.
Yes.
Yes, sir. Make it easy for us, sir.
or
Yeah,
I will leave the,
definitely.
shall I leave the meeting?
But I need some more hands.
Yes, ma'am.
Shall I leave
Single-handedly,
the
I cannot
meeting?
do that.
Because I'm not finding it, Jayashree.
Ma'am, just
No,
tap on the
Devi,
screen,
you are-
ma'am.
Dr.
Yeah.
Devi, you
Tap.
quit. Stop
Tap
sharing and
Yeah, my
and
PowerPoint. Okay. Yeah.
yes.
yes, ma'am.
Now go.
Yes, ma'am. Thank you. Sir, visible, sir?
Visible.
Yes, yes.
Video also.
Yes, sir.
Your video.
Yes, sir. Yes, sir. I'll show, sir. Good afternoon, all. I'm presenting phenotypic heterogeneity of a single disease. So, first case is Mr. X, 35-year-old male from Arandangi. He studied BCom and works as supplier assistant in a restaurant. And he presented with chief complaints of involuntary movements of left upper limb for 6 months, right upper limb for 4 months, with difficulty in walking for 3 months, and slurring of speech for 3 months. His involuntary movements were insidious in onset, noticed by him while handling bottles at workplace, which dropped from his hands initially from both left followed by right hand. These abnormal movements were purposeless, non-repetitive, irregular, predominantly involving the distal part of both upper limbs. These movements were progressive over days and present when awake and aggravated with actions and while walking, and disappears in sleep. His movements affects his activities of daily living. For the past 4 months, he is unemployed because of these involuntary movements. He had difficulty in walking for past 3 months. He had sudden twisting of ankle, and he used to walk with slightly wide base with varying step length, but not associated with any falls. He also had slurring of speech for the past 3 months. He was unable to speak full sentences, with words being irregular with variation in volume, so that his relatives could not understand his speech easily nowadays. He had history of involuntary twisting of tongue while speaking and eating, which causes spitting of food from his mouth. No history such of higher mental function involvement, no behavioral or psychiatric disturbances, no cranial nerve involvement, no motor, sensory, cerebellar, autonomic system involvement, motor system in the form of weakness, no history of seizures, no significant past personal, family, treatment or history or drug intake in the past. So on examination, general examination and vitals were normal in this patient, except for traumatic amputation of right, second, third, and fourth fingers in childhood due to childhood trauma. MMSE was 28/28. He was conscious oriented. Cranial nerves were normal. There was no case palsy. Speech dysarthria was present. Slurring for linguals were present with low volume, and speech was interrupted by twisting of tongue. He had ocal tics, which were suppressible partially. Mild hypotonia of all limbs were present. Power was 5/5 in all limbs. Head and neck, involuntary jerky movements of the head, predominantly in the anteroposterior direction, while sitting and standing, and it got reduced on lying down. Limbs show irregular, brief, semi-purposive, non-rhythmic movements which flows from distal to proximal parts of the limbs, which are present at rest, increase with activity, and not during sleep. Tongue pushing movements and frequent lip smacking, grimacing were seen. Milkmaid grip and rubberman gait was present. Sensory, cerebellar, autonomic system, and other system examination were normal in the patient. So I'll share the video, sir. Hello?
Yeah, go ahead.
Yes, sir. Yes, sir. This was the video of this patient while sitting. He had a predominantly lower half of the face involvement, frequent tongue twisting movements, sudden jerky movement of the head in anteroposterior direction, frequent grimacing, and parakinesias were also present. Typical coriform movements were present in his right upper limb. This is a walking video. He has typical rubberman gait with varying step length, slightly wide based. Sir, this patient presented with the involuntary movements predominantly in the form of chorea, sir. So structures involved are basal ganglia and its connection affecting the indirect pathway predominantly. So differentials considered in this case were Wilson's disease, neuroacanthocytosis, choreacanthocytosis, Huntington's disease like disease 2, neurodegeneration with brain iron accumulation, PCAN, McLeod syndrome, autoimmune and metabolic were down the list. We investigated the patient. CBC showed mild anemia. Peripheral smear picture I'll show. Renal and liver function tests were normal. Serum ferritin was normal. ESR, CRP, ASLO were normal. Fasting lipid profile, thyroid function were normal. Viral markers were negative. No KF ring. Nerve conduction study was normal. Serum creatinine kinase was normal. ECG, echo were normal. Chest X-ray, ultrasound was normal. So this is the peripheral smear picture of the patient, which showed normocytic normochromic anemia with acanthocytes. Here we could see the acanthocytes, which are abnormal blood RBCs with the spiky projections over the surface. So in this patient, we had around more than 8% of RBCs were composed of acanthocytes, which was significant. More than 5 is significant, sir. So this is the NCS report of the patient, which turned out to be normal. This is a CT brain of the patient, which showed mild caudate atrophy. Patient was not cooperative for MRI, sir, so we didn't do MRI, and also he did not turn up. So the diagnosis of choreacanthocytosis was clinically made, and he was treated with tablet clonazepam and tetrabenazine. Shall I move to second case, sir?
Yes. Proceed.
Yes, sir. Yes, sir. Second case is Mr. Y, 38-year-old male, studied up to 8th grade, welder from Karaikal, came with complaints of slowness and tremulousness of the left upper limb for past 2 years, with dragging of left lower limb for 1.5 years, with slowness of daily activities for 1 year. Patient noticed insidious onset slowness in activities of left upper limb, like while picking an object, and it was associated with stiffness of the limb over 2 years. He also had tremulousness of left upper limb, mainly while at rest and picking up objects, but not while holding an object or during sleep. Over next 6 months, he noticed slowness of left lower limb. He used to drag his left leg while walking. However, he did not give history which is suggestive of limb weakness. His speech became softer, low in volume and monotonous, so that he had to repeat sentences multiple times to his relatives to understand his whatever he has to communicate. For the past 6 months, he developed slowness on the right side of the body, upper limb followed by the lower limb. He had slowness of walking, his steps were short, and he had to take multiple turns while multiple steps while turning. There was no history of falls, postural giddiness, bladder disturbances, unsteadiness while walking, no history such to of myoclonic jerks or apraxia, no history such to of cognitive impairment, visual hallucination, sleep disturbances, no history of cranial nerve dysfunction, no seizures, behavioral disturbances. No history of weakness or sensory disturbance. Past family history were significant. Personal history, he's a smoker, smokes 1 pack for past 12 years. On examination, general examination and vitals were normal in this case. MMSE was 30/30. Speech, he had low volume monotonous speech with loss of inflection and no fascination. Cranial nerves were normal. There was no vertical gaze palsy. Saccades, antisaccades and pursuit were normal. Fundus was normal. Tone, rigidity of all 4 limbs were present, left more than right. Cogwheel rigidity present in the distal parts like fingers and wrist, while lead pipe rigidity is present on the other joints. Power was 5/5 in all limbs. DTRs were brisk, however, plantar was flexor. Sensory, cerebellar, and autonomic system were normal. Coming to extrapyramidal system, blink rate was reduced. It was around 6 per minute. Meyerson sign was non-accommodative. Hypomimia was present. Tone, rigidity, as described earlier, was present. Bradykinesia was present, which was more predominant on the left side than the right side. Rest tremor is present on the left upper limb. Pull test was positive. Gait, posture and stance were normal. Step length, stride length was reduced. Cadence was also reduced. Arm swing was reduced. End block turning was present without freezing or hesitation at the start or end of the gait. I'll share his video, sir.
Yes.
So this was the video. This was taken actually after starting the on treatment. So his bradykinesias were slightly improved. Only gait video I have, sir. Arm swing were reduced. Facial hypomimia noted. Reduced blink was also noted in this video itself.
Okay, Ram.
This patient presented to us with hypokinetic movement disorder, predominantly with rest tremors and bradykinesia. So structures involved are basal ganglia and its connections. Direct pathways involved. Differentials considered were young onset Parkinson's disease, Wilson's disease, neuroacanthocytosis, Parkinson pyramidal syndrome, rapid onset Parkinson's disease, NBIA, Huntington's disease, and toxin induced. Since patient was welder, manganese exposure was also there, so we consider toxin induced movement disorder. Investigation showed CBC was normal. PSA, peripheral smear I'll show later. Renal and liver function tests were normal. Serum ferritin normal. ESR-CRP was normal. Fasting lipid profile CK were normal. Thyroid function was normal. Serology was negative. There was no KF-ring. Nerve conduction study was normal. Echo and ECG were normal. Chest X-ray ultrasound were normal. This is his peripheral smear. Showed acanthocytes of around 7%, which was also significant. This is the nerve conduction study of the patient, which turned out to be normal. The MRI of this patient, MRI of this patient was normal. There were basal ganglia involvement was not there in the MRI. So this patient presented with predominantly hypokinetic movement disorder. He was treated with tablet pacitane and Syndopa. With Syndopa, his clinical symptoms improved well. And he is doing well now, sir. Shall I proceed to the third case, sir?
Yes.
No, your
Third
conclusion.
case.
No, your conclusion.
Sir, actually, for second case, various differentials were considered, sir. But with the presence of acanthocytes, we concluded it to be neuroacanthocytosis, sir. However, we could not confirm it with genetic testing, sir.
Yeah, neuroacanthocytosis with Parkinsonic features. How common
Yes, sir.
and how often does it happen?
Sir, neuroacanthocytes can be present in various other conditions like hypothyroidism, A-beta lipoproteinemia, sir, and liver diseases. Onset of neuroacanthocytosis with the Parkinsonism is slight rare, sir, when compared to the other movement disorders. So this case is somewhat rare, sir. Parkinsonism with the acanthocytosis can be neuroacanthocytosis, but Parkinsonism as a presenting feature in neuroacanthocytosis is very rare, sir. Exact percentage I could not find out, but chorea and dystonia are more common movement disorders, sir.
So what other causes of acanthocytosis did you look for in this patient?
Sir, in this patient, we worked up for liver cirrhosis, sir. LFT turned out to be normal. LFT turned out to be normal, and ultrasound was also, there was no cirrhosis, sir. And A-beta lipoproteinemia fasting lipid profile was normal in this patient, sir. And hypothyroidism we ruled out by doing thyroid function test, sir.
Okay. Okay, continue.
Yes, sir. So the third case is Mrs. X, who is a 40-year female, studied up to 10th class, housewife from Puducherry, came with complaints of involuntary perioral movements for past 2 years, with slurring of speech for 2 years, and difficulty in walking for the past 1 year. Patient noticed insidious onset abnormal perioral movements in the form of lip smacking, frequent grimacing, clenching of teeth irregularly, along with involuntary tongue protrusion without tendency to bite lips or tongue for the past 2 years. Patient had involuntary twisting of tongue within her mouth, causing frequent spitting of food during eating, associated with drooling of saliva. She also had dysphagia with choking and coughing spells. She had slurring of speech. She speaks with short phrases, with words being irregular, with occasional abnormal sounds, which were partly suppressible. She had involuntary movements involving both lower limbs, resulting in abnormal posturing and twisting of the ankle were present, causing difficulty in walking for the past 1 year. However, she did not have weakness of the lower limbs. Her involuntary movements aggravated on walking, performing any work, and anxiety, and decreased on lying down and were absent during sleep. Her movements were progressive, affecting her daily activities. No history of behavioral or psychiatric symptoms or cognitive dysfunction. No history suggestive of cranial nerve, motor, sensory, cerebellar, or autonomic system involvement. She is married. She has no children. No significant past family treatment history. No history such of significant drug intake. So on general examination, general examination of the patient was normal, vitals were normal, MMSE was 30/30, cranial nerves were normal, no gaze palsies. She also had lingual dysarthria, bulk tone and power were normal. Frequent perioral movements in the form of lip smacking and grimacing were present. She also had vocal tics, tongue pushing dystonia was present. Dystonic posturing of both ankles were present during walking. Gait was wide-based with irregular and varying steps. Sensory, cerebellar, and autonomic system examination were normal. So I'll play the video, sir.
There's no audio.
Now, So now it's audible, sir.
No.
Sir, I don't know how to switch on the audio, sir.
Doesn't matter. Go ahead.
Okay, sir. Sir, yes, sir. She had lower face involvement, tongue pushing dystonia, sir. And she says that she is not able to have food because of this tongue pushing dystonia, sir. Sir, she had dystonia in both the lower limbs while walking, sir, predominantly the ankle. And she had rubberman gait also, sir. So- So we were, the differential diagnosis were the same for this patient also. We considered Wilson's disease, neuroacanthocytosis, Huntington's disease, NBIA PCAN, and McLeod syndrome, autoimmune and metabolic conditions. So we worked up with routine blood investigations. All her blood investigations were normal: CBC, liver function test, renal profile, serum ferritin, ESR, fasting lipid profile, CK were normal. Thyroid function test was normal. Serology was negative. No KF ring. Nerve conduction study was normal. ECG echo was normal. Chest X-ray and ultrasound were normal. So this is the peripheral smear of this patient. She also had acanthocytosis with significant number of more than 11%. NCS turned out to be normal. MRI of this patient showed a caudate atrophy with prominent frontal horns of the lateral ventricles. So we diagnosed her with chorioacanthocytosis disorder. Patient was treated symptomatically with the tablet clonazepam and tablet tetrabenazine, and she also did not turn up for further follow-up, sir. And genetic we could not do in all three cases. A few words about evolving spectrum of neuroacanthocytosis. Sir, shall I proceed, sir?
Yeah.
Yes, sir. Neuroacanthocytosis syndrome encompasses two very rare diseases, which includes chorioacanthocytosis and McLeod syndrome, which are due to VPS13A mutation and XK mutation. These syndromes were due to mutation. These were phenotypically similar disorders that affect predominantly the basal ganglia and result in involuntary abnormal movements associated with neuropsychiatric and cognitive alterations. So a few words about the taxonomy of the neuroacanthocytosis syndromes. Previously, Erwin Levin and Edmond Critchley investigated two separate families with the basal ganglia involvement in the form of involuntary movements associated with the acanthocytosis in peripheral smear. So in 1970s, Hartley did an extensive evaluation of the same disease, where he found out to have basal ganglia involvement, involuntary movements in the form of chorea, Parkinsonism, and dystonia, and also associated with acanthocytosis. Then the term neuroacanthocytosis came into existence, and further in 2001 and 1 to 17, molecular investigation involved various genetic mutations were approved in such cases like VPS 13A, PCAN, and other mutations. So there they encompassed 4 diseases like chorea and acanthocytosis, McLeod syndrome, PCAN, HARP, and Huntington's disease like 2. And the further evolving spectrum excluded the Huntington's like 2 disease and PCAN because the PCAN and HDL2 disease involved different pathophysiology, and in HDL2 around 12 cases were studied in detail where there was no acanthocytosis. So these 2 cases again were excluded. So in 2017 to 2022, VPS 13 mutation and XK disease were taken into consideration. VPS is vacuolar protein sorting gene, which is a group of genes which has 4 subtypes like A, B, and A, B, C, D. B, C, D are involved in other pathophysiological mechanisms, and acanthocytes were absent in those disorders. So only VPS 13A and XX disease were considered. So these 2 genes predominantly involved in lipid transfer from the endoplasmic reticulum of the cell to the plasma membrane. So these act as protein scramble lipid scramble protein. So they are known as bulk lipid transfer proteins, and these disorders are now termed as bulk lipid transfer disorders, so which includes VPS 13A and XX disease. So red flag signs of VPS 13A and XX disease are triad of movement disorder, cognitive and behavioral impairment should be there, with prominent orofacial chorea, dystonia. Feeding dystonia and tics are very significant for characteristic for VPS 13A disease. Seizures, diminished or absent tendon reflexes. Cardiomyopathy is in more favor of XK disease, and acanthocytes is not specific, neither is present is necessary for the diagnosis of the disease, and elevated creatine kinase and transaminases may be present. Atrophy of the caudate on neuroimaging is also present. Investigations, genomic testing is diagnostic. Ancillary tests like peripheral smear for acanthocytes, LFT, echo, and NCS EMG should be done. Creatine kinase should be done, and neuroimaging, preferably MRI, should be done in these cases. Management, these cases have no cure. Multidisciplinary supportive care should be done in these patients. Like in case of chorea, we give dopa depleters, and orofacial dyskinesia sticks, we give Botox. And for generalized dystonia, we can treat them with amantadine or benzodiazepine. Parkinsonism is treated with dopaminergic agents. Dysarthria, speech therapy should be given. Dysphagia, gastrostomy tube can be considered. For seizures, we give phenytoin, clobazam, and valproate. And carbamazepine, lamotrigine should be avoided in these cases as they may increase the involuntary movements. And cognitive decline, occupational and neuropsychological therapy should be given. For behavioral disturbances, antidepressants and antipsychotics can be given accordingly. Thank you, sir.
Thank you, Dr. Jayashree. You have
Yes,
given a good information about the diseases. Thank
Yes, sir.
you.
Thank you,
Any
sir.
opinion or any comment? Anybody has got?
In the last conference, Dr. Satish Chandra, Professor Satish Chandra spoke that from genomic diagnosis, we are going to the proteomic diagnosis. From proteomic diagnosis to the molecule diagnosis, like that. No, we are going into the cell, intracellular signaling pathway, and all those probably we have to look into. In the last case, probably it's not very convincing because it looks more of a functional disorder. And how did he rule out? She doesn't have any other feature. Perioral, well, she has got more of cervical movement.
Yes,
and she looks more of well dressed and well nourished.
So
And
she
doesn't have.
So she had a tongue pushing dystonia, sir. She had a tongue
And
pushing
even
dystonia.
tongue pushing dystonia looks like a functional look. I
And,
don't know.
And when walking, she had a generalized dystonia, which was more on the right side, sir. More on the right when compared to the
Dystonia during walking. I'm sorry, I'm not very much convinced.
Oh,
I
okay.
don't know. The third case, probably I would have, if she has come to my clinic, I would have diagnosed functional. The whole thing is probably, I may be wrong. After seeing the peripheral smear and all, probably looking at the, so that's what I said. After seeing the investigation and after seeing that, we are revising our diagnosis. The clinical part goes down when you look like that. Again, in the boy doesn't have, there's 2 fingers he has lost. Is it mutilation or something like that?
Sir, actually, he gives history of childhood trauma due to cracker burst, sir.
That's all.
Yes,
And
sir.
just because acanthocytes are seen, less than some 78%.
Yes, sir.
Well, that alone gives make it a diagnosis of acanthocytosis. The clinical feature of neuroacanthocytosis, what we have read, is that small muscle wasting, raised CPK, and the patient will have self-mutilation. All those things are absent in those cases.
Yes, sir. Yes, sir.
So
In
a
all
lot
3
of
cases, all.
variations. As you said, that after the genomic sequencing, we have to revise our clinical findings. And clinical
Yes.
features, what we see as a typical clinical findings, are not seen. When we don't see and we want to diagnose with the investigation, probably we have to look into the genomic diagnosis. Like that, probably we go back and look for those things. This is what is happening now in the clinical neurology after your presentation. Of all the cases, that's what I felt as a retired person.
Yes, sir.
Not retired.
I'm sorry, sir.
That is removed from the recording.
Oh, thank you.
I am sorry, Chairman, I have got the right to give actions.
Yes, sir.
Paranjoti has got personal right also.
Yes.
The idea of presenting these 3 cases is for the phenotypic descriptions, actually. While of the chorea acanthocytosis syndrome, one presenting as a mixed movement disorder, one presenting predominantly with chorea and tics, and another case presenting only as Parkinson's. Just like for Wilson's, there used to be a Marsden's classification of 4 different forms. So we thought we had 3 different phenotypic presentation. And another idea was like previous 3 cases, we all had genetic test done. For this case, we haven't, for all these 3 cases, we haven't done genetics. It's just a phenotypic clinical presentation, sir. Thank you, sir.
Yes, sir. Thank you, sir.
Thank you, sir.
Thank you very much. Even the VPS 13A, when you go into the net, it gives all the findings what you have shown.
Yes, sir. Yes.
I really congratulate you for that.
Yes, sir. We also want to, look at this disease and how it has evolved.
Yeah,
Now,
that's
genetic, yes,
excellent. This is excellent. This is modern neurology. Excellent.
Suresh, is it not possible to do the genetic testing now?
Sir, அவங்க 3 பேரும், all 3 are very poor, sir. Actually,
Oh,
nowadays
okay.
we are motivating every patient to do genetic. Whenever we have a diagnostic dilemma, all these 3 patients, they didn't do, sir, actually.
How much does it cost?
Sir, now we are doing between 10,000 to 12,000, sir.
12,000, sir. 12,000 it comes.
Yeah, MedGenome தானா?
இதுல நாம ஹாண்டர்சன்ல பண்றோம், sir. Anderson Diagnostics.
Yeah, we are also doing that. And
Actually, there is a there is a geneticist, sir. He calls up and he discusses with us also, sir, what ought to be done, what not to be done. So we make a discussion with him and then we go again with the testing. Our base
Yeah.
Shiv Shankar, sir. Shiv Shankar.
The Hyderabad Central Institute அனுப்ப முடியாதா?
So actually, before I had sent for few spinocerebellar ataxia, sir. Actually, அப்பலாம் வந்து actually it's very cheap. Actually, அங்க 1,000 per scar.
It is covered by insurance, sir. So it's covered by insurance, and hence most of the institutes, the corporates and all, they do it. They take it and they cover it in the institute, in the insurance scheme.
Sir,
Hyderabad 1,500 rupees பண்ணிட்டு இருந்தாங்கல்ல?
இல்ல per gene, sir, actually, per scar gene. But the thing is, sir, you have to call them up, you have to fix, and then you have to take the sample through another lab, and that lab has to send it to them, sir.
Sir, as he says, it is easy, sir. Anderson just phone up and then he comes and takes it.
Cost is the factor, sir. Cost
The cost கூட இப்போ இவங்க பாத்துக்கிறாங்க, sir. under the corporate lab people. You just inform them, it is done, sir.
No,
Next
these
day, they
poor-
give the blood and they go.
No, for these poor patients, what is the alternative?
Oh, I don't know. Government hospital, we still do not know, sir.
So for some Pondicherry patient, there is a CM fund, sir. அது apply பண்ணி அவங்களுக்கு கிடைக்கிறதுக்கு 2 years ஆயிடும், sir. So by the time they used to come and nag me, please, I mean, hasten. அதுக்குள்ள we get fed up, sir. So better to motivate them to make themselves pay for it, actually. But otherwise, நீங்க சொன்ன point correct தான், sir. We need to have some mechanism in which poor patients are benefited so that they can do it free of cost.
Or at least, sir, reduced cost.
Already 10,000 seems to be a very reduced cost, sir. I'm not sure whether they can reduce it even further.
Okay, shall we conclude, Professor?
Yes, sir. Yes, sir.
Yes, sir. Thank you,
Yes,
sir.
sir.
Thank
Thank
you,
you all
Suresh.
for the good
Sir, thank you, sir.
presentation, everything. Number one, all the 4 speakers have done a good job in presenting this case, and that too, all the cases are equally important and informative. Number 2, Dr. Suresh has given a good guidance to all the patients. We must congratulate him for this wonderful work. 3, I must thank Professor Natarajan, but he should not punish me for crossing the 1.5 hour.
Not at all, sir. Not at all. You take your time. Three. I would say.
Don't remove me from the chairmanship because of overriding the number.
Three, I would say, congratulate Dr. Devi for a painstaking genetic workup of the cases.
Yes.
Yeah.
Yes.
Thank you, sir. Thank you, sir.
Today webinar is on par with the NIMANS clinical society meeting. That is why we are very much benefited and a lot of information we have received.
Sir, we are progressing, sir.
Quality.
Paranjoti, sir, we are progressing.
Yes, sir.
Yes. Then we must thank the participants for giving the good discussion. But
And
should
all
never
of them presented well. All of them presented well.
Well, should never retire from any of the practice. That is why I request the participants to take an active part till our last date. Thank you all. I thank the Sun Pharma for giving the support. Thank you all. We will meet again next month.
Thank you, Paranjoti, and thanks,
Thank you.
Sama. Thank you, Suresh, and thank
Thank you.
all the presenters and the discussants, particularly Professor Megandan for his active participation, and so also Chitramalam. It's never complete without Chitramalam's participation.
Yes,
Particularly when Suresh is there.
yes. Thank you, sir.
Thank all of you.
Thank you, sir.
Thank you, Kani. Can we leave?
Thank you, sir.
Yeah, thank you very much. Thank you very much. Well done.
Thank you, sir.
Yes, sir.
Thank you, sir.
I just want to have a word. Next month it will be Kalpana. She needs all your encouragement. Kalpana is just graduated from MIN, and she is very enthusiastic in presenting cases. Again, 4 cases. So we need your active participation and encouragement much more because she is just coming into the fold of presenting. Thank you.
Sure, sir.
Thank you, Kani.
Welcome, sir. Thank you, sir.
Thank you.